Congress of Cardiology. I'm very proud to be here with you. And as mentioned, the title of my presentation today will be Integrated Care for Management of Atrial Fibrillation. Well, atrial fibrillation is really a very concerning disease. You know that the prevalence of atrial fibrillation is very high in various countries. For example, here you see that in North America, it's more than 900 per 100,000 people who have atrial fibrillation. You see that the prevalence is a bit lower in Europe, but still very, very high. And you see here that in Africa and Asia, somehow, the prevalence seems to be lower, probably due to genetic factors, but also maybe due to the access of care in some parts of Africa, for example. So a very, very concerning and highly prevalent disease is atrial fibrillation. And what you can see here is that atrial fibrillation is one of the 25 leading causes of global DALYs. DALYs is disease-adjusted life years, and you see that in this global burden of disease from 1990 to 219, the atrial fibrillation progresses as a cause of a DALY, meaning that atrial fibrillation is really being not only more prevalent, but also giving more morbidity and more mortality, because DALY is an integration of morbidity and mortality in life expectancy. And here is the contribution of atrial fibrillation in patients more than 70 years to death. And you see that it's really very high in some countries, the proportion of death due to atrial fibrillation. Here you see that it's about 180, nearly 200 per 100,000 deaths, which are caused by atrial fibrillation. In other countries, it's lower, and you see that, not surprisingly, in Africa and Asia, as I mentioned before, since the prevalence of the disease is lower, the mortality due to the disease at the age of 70 years or more is lower. So really a very concerning disease, highly prevalent, and really leading to a high morbidity in patients over 75 years and high mortality in patients over 70 years. Well, the problem with atrial fibrillation is that it's not only an arrhythmia. The consequences of atrial fibrillation are not only consequences on the heart, they also involve many, many other organs. You see here, for example, in this slide coming from the 2020 ESC guidelines, that atrial fibrillation may promote death. We already mentioned it. It may promote stroke, so it really has, as we all know, it really has huge consequences on the brain. It also may promote left ventricular dysfunction and heart failure, which is not surprising. But also it may promote dementia. And this is something which was recently shown. And you see that the hazard ratio for dementia, irrespective of stroke history, is 1.4 to 1.6, which is very high. It also provides some depression. So taking into consideration a patient with atrial fibrillation, we will have to take into consideration cognitive function, but also depression. It also impairs quality of life. More than 60% of the patients mention that their quality of life is lower. And also it is a leading cause of hospitalization, between 10 and 40% annual hospitalization rates. So really taking into account atrial fibrillation means that we will have to take into account all these issues and all these aspects, potential aspects of the arrhythmia in a given patient. And also, what is important to keep in mind is that atrial fibrillation, of course, is promoted by some factors that cannot be changed, like genetics, aging, ethnicity, male sex, but also to many, many other comorbidities which can be changed. And this is probably the rational, the higher rational which is behind having a holistic approach to the patient with atrial fibrillation. We should not only treat the patient, we should anticoagulate the patient, we should treat the symptoms, but we should also promote a control of these comorbidities in order to decrease the atrial fibrillation burden. Well, what is the management of atrial fibrillation, which is recommended by the 2020 ESC guidelines for diagnosis and management of atrial fibrillation? You all know this A, B, C treatment, which is recommended. A means anticoagulation. Identify a patient, offer stroke prevention, and choose the right drug, which is a NOAC in the vast majority of the patients. Better symptom control. You should assess symptoms. This is very important, and we already discussed the quality of life assessment, which is very important in the patients. And then you should go to optimize rate control and consider a rhythm control strategy, going through cardioversion, antiarrhythmic drugs, and ablation. And finally, C is of paramount importance. C is comorbidity and cardiovascular risk factors management. This is very important. We already mentioned that these comorbidities play a very important role in promoting atrial fibrillation. Obesity reduction, of course, is very important. Regular exercise, regular reduction of alcohol use, we will discuss it later, but this is clearly very important. And all these A, B, and C strategies should be promoted all together at the same time in order to have a clear approach of our patient. And this is really the basis for the integrated approach that we promote for atrial fibrillation. Regarding anticoagulation, it's really more than only prescribing something on a paper sheet. It's really involving many people around the patient in order to optimize the adherence to the treatment. Patient, of course, family should be educated. Family members should be involved in the treatment of the given patient. You also know that the pharmacist and other people, and also the doctor, the physician should be involved in the rules in order not to forget the drug administration, drug intake. Technology might aid the patient. We should also use a remote electronic monitoring of the patient in order to know if they really took the drug. Also, we should think about once versus twice daily regimen in order to optimize the adherence. And the pharmacy is very, very important in order to really be sure that the patient really takes the drug. So it's not only something for the patient, the prescription, but it's something which should be shared with many, many people. And this is also true during follow-up. You see that regular follow-up of your patient will involve the general practitioner, cardiologist, and also some clinics of anticoagulation and atrial fibrillation. So it's really a continuous process after the initial prescription of the drug. And this continuous process involves many, many people in order to have an integrated approach of the anticoagulation of the patient. And you see here that the patient may also consult some other specialist or a multidisciplinary team. So really a global approach for anticoagulation. Regarding better symptom control, of course, when you think about better symptom control, you think about cardioversion, you think about antiarrhythmic drugs, about ablation, about rate control. But we also should think about the upstream therapies which should be given to the patient. And this is a very important study which was published a couple of years ago in the European Heart Journal. First author was Isabel van Gelder. And you see here that this was a team of Isabel van Gelder. And you see here that in this study, patients with early persistent atrial fibrillation and heart failure were offered two possibilities by randomization, either a conventional approach with electrical cardioversion and rhythm control and heart failure therapy according to guidelines, but also a risk factor-driven upstream. And on top of the conventional approach, in this group, the patients receive mineralocorticoid receptor antagonists, statins, AC inhibitors, and/or angiotensin receptor blockers, and cardiac rehabilitation, including physical activity, dietary restriction, and counseling. And this, of course, was both groups were followed in order to see how many patients were still in sinus rhythm after 1 year. And you see here that at 1 year, on the Holter monitoring which was performed, 75% of the patients in the targeted therapy, including more than the conventional therapy, the upstream therapy on top of the conventional therapy, 75% were on sinus rhythm, and only 63% in the other group. And this was a superiority hypothesis which was proven. So really, going beyond the treatment, the antiarrhythmic treatment or the rate control treatment is very important in atrial fibrillation. And this is why an integrated approach is so important also for better symptom control in this patient. So it is important for anticoagulation, it is important for better symptom control, and it is also very, very important, and this really makes sense, for comorbidity management. For example, you know that the obesity is promoting atrial fibrillation. There are many, many reasons for promotion of atrial fibrillation through chronic inflammation, sleep apnea, gastroesophageal reflux, renal compression, but also through hypertension, coronary artery disease, and diabetes, and this, of course, may be promoting atrial fibrillation. On the other way, the physical activity, when performed optimally, meaning 150 minutes per week of moderate activity, or no more than 70 minutes per week of vigorous activity, and or 20-day walking, this promotes the sinus rhythm. This prevents atrial fibrillation. But we should keep in mind that excessive physical activity by increasing the lean body mass of the patient will be also promoting atrial fibrillation. The increase in lean body mass promotes atrial fibrillation by many, many potential mechanisms, including hypertrophy, myostatin, including the enlargement of the heart, and at the end, of course, atrial fibrillation is promoted. So this is a key message here. Having an optimal physical activity, not excessive and not, of course, too low and becoming obese. Obesity is a strong factor for atrial fibrillation. We all know this by seeing our patients. You see here that for obesity, hazard ratio for incident atrial fibrillation is 1.45 for women and 1.42 for men. This is clearly shown here. Obese patients here in bold are clearly different from overweight and normal in men, and here clearly different from normal, but not so different from overweight patients. And you see that this obesity is a promoting factor for atrial fibrillation, but what is very concerning is that obesity is very highly prevalent in our countries. You see here in Europe, for example, that obesity is the increase in body mass index is very important. The increase is present in more than 53% of the patients. You know, an increased body mass index in more than 53% of the patients. This is different from country to country. For example, in my country, France, I'm very proud to see that it's only, but it's a lot, 47% of the patients who are with an increased body mass index more than 25, and in Italy, it's a bit lower. In other countries, it's higher. But regarding obesity, you see that obesity is clearly highly prevalent in our European countries. Highly prevalent here in these countries here in red. including Spain, including Central Europe, including Greece and South Europe. It is also highly prevalent in my country, for example, in Western Europe, and the less is present in Italy, which is good news, very good news. And so the numbers are here. 52% of Europeans are overweight, and 40 to 50% of those are obese. And this is, of course, this is very concerning regarding atrial fibrillation. The comorbidity treatment, the involvement of comorbidity, taking consideration of comorbidities in our daily practice is very important for many of them. Hypertension, obesity, when they are treated, the results of atrial fibrillation ablation are much better. Diabetes, obstructive sleep apnea, physical inactivity, smoking, alcohol, and hyperlipidemia, all these factors were, when taken into consideration and when adequately managed, they really impact the result of the rhythm control by the ablation. You see here in this legacy study, which is a well-known study, that patients who had lowering of their body weight were really much better responders to ablation than the other ones, which here weight loss is much better than no weight loss or very low weight loss. And the total AF freedom after ablation was much higher in patients with more than 10% weight loss. These were, of course, overweight patients. It was a bit lower in patients with a lower weight loss, and it was not good in patients with no weight loss or any increase in weight. And here in the ARREST AF study, it's exactly the same, but on top of the weight, there was holistic management of the patients, including blood pressure control, weight management, we already discussed it, lipid management, glycemic control, sleep disorder breathing management, and smoking and alcohol. And you see here that the better you controlled these factors, the better are the results of the ablation. In the group which was controlled for risk factors, the results of ablation were much better than in the other group. You see here that the recurrence rate is very high in these patients. These are the targets that you should tell to your patient. Regarding alcohol, no more than 2 drinks a day. This is very important to have in mind. Regarding obesity, weight loss more than 10% body weight when they are overweight, of course. Regarding diabetes, having a good glucose control with the less than 7 hemoglobin A1C. Regarding positive obstructive sleep apnea, of course, a good treatment is important. And regarding hypertension, we should stick to a lower systolic blood pressure than 140, but higher than 110. Of course, not in order not to have syncope. Another and the last aspect I would like to discuss with you, which is important when talking about an integrated approach of atrial fibrillation, is the screening of atrial fibrillation. We now have some studies showing or starting to show that screening might be interesting in some subgroup of patients, particularly patients over 75 years of age. This was shown by a Swedish stroke stop study. And what is very important is that when engaging your patients in a screening strategy, as mentioned here by the guidelines, you should refer the patient to a structured refer platform after the detection of atrial fibrillation. Not only detect and leave the patient alone, you should detect and send the patient to a global and integrated approach of the atrial fibrillation. This is very important also when considering a screening strategy. So yes, the integrated management of atrial fibrillation is very important. It will go through optimize stroke prevention by anticoagulation, symptom control, management of cardiovascular risk factors. It will involve many people, patient, of course, healthcare professional should be educated, lifestyle modification should be proposed to the patient, psychosocial management should all be proposed to the patient, and also strategy to promote adherence to medication. And this is why a multidisciplinary team approach is so important. And here you have an example, including the nurse, family carer, cardiologist, pharmacist, general practitioner, in order to really have a complete, full, holistic approach of the atrial fibrillation in these patients. Well, I would like to finish here with my last slide, telling that there is no doubt that atrial fibrillation is becoming an epidemic in our countries, at least. In Asia, it's a bit different, but in Western Europe, it's very important. And this epidemic should be really prevented. We should prevent, and we should have a primordial prevention in very young patients, primary prevention in patients between 40 and 60, secondary prevention after the age of 60, and this probably will involve a fully global approach of atrial fibrillation, including the treatment of all comorbidities. So really integrated approach of atrial fibrillation is key. I thank you.